Hello, and welcome to the Body Fusion Therapy Podcast. I'm your host, Dr. Heather Demirci. Today's episode is going to be a part of a series, and the series is going to be peppered in throughout different episodes. It's not going to be all at once, but we're going to start talking about how to figure out what the leak is. Now, if you don't know what I'm talking about, I use the analogy that injuries are like a leak through your ceiling. That ceiling tile where the water's coming down is the site of pain. But water didn't just magically appear there. It came from somewhere else. So my job is to find the leak, stop the leak, and then replace the ceiling tile. More conventional medicine can be more about replacing ceiling tiles, which I joke is a great business model because people have to keep coming back again and again. Because guess what? The leak is still going to be there and that new ceiling tile is going to get ruined. But I would much rather be known as the good handy person who can fix the leak and get the job done. So I want to talk about different causes for the leak. So today's episode is going to be more about this idea of hypo versus hypermobility. So not enough motion, then creating too much motion, and how that kind of plays into finding the root cause of your pain. So we're going to talk about what am I talking about with this philosophy of hypo versus hypermobility. Then I'm going to give examples of it associated with the joints, the nerves, and the organs, and then how to kind of assess and treat from there. So let's first talk about hypo versus hypermobility. So hypomobility is not enough motion or too little motion, while a hypermobility is too much motion. So just moving way too much through the range of motion that you're asking it to. Now, the site of pain is usually the hypermobility, the too much motion. Now, why is this? It's because there is stretch that is happening at that joint or within those tissues past what your body is meant to do. You're asking more of it, and it's going to be causing pain because you're going to be stretching those nerve fibers as well. So hypermobilities usually cause the pain. But what I want you guys to try to open up your minds to is that the hypermobility might just be the symptom of the bigger problem being an area of not enough motion or hypomobility. So the hypomobility, so an area of the body that is stuck, that isn't able to move right, that's just kind of jammed, is causing its other area of our body to have too much motion because you still want to do the motion. So I see this hypo versus hypermobility more in kind of the acute and subacute, not so much in the chronic stages of injuries. As it gets to the really chronic stages, then this hypermobility starts to become a hypomobility in its own right. And then you're just not moving at all. So it's happening a little bit earlier and through the injury process of this not enough range of motion creating too much range of motion. So to really truly address the issue, it's not so much the strengthening around the hypermobility. The tendency of healthcare providers is, well, we need to strengthen that you have this area that's moving too much, so we just need to strengthen it. Well, yes, it is important to strengthen it, but if that foundation of that house is still moving too much, the strengthening of it is only going to do so much. You really need to affect that area where it's not moving enough so it has more give, and then go back and strengthen the area of hypermobility. But if I'm to be honest, usually when you fix the area of hypomobility, not enough motion, then that area of hypermobility doesn't need a lot of strengthening because it's kind of gone back to the normal motion that it needs to go through. So sometimes you don't have to do it, but it's always good to strengthen because obviously there was something wrong in the system where it wasn't working the way that it's supposed to. So strengthening it is always a good idea. But I think you'll be surprised how that area of hypermobility no longer exists if you get to the root cause of the problem. Surprise, surprise, you fix that leak, it's no longer going to be an issue. So let's get into some examples because you might be thinking, what is she talking about? So if we're looking at joints, The biggest place where I can see this is actually in an SI joint issue. So if someone's kind of low back going to their pelvis, their SI joint is painful on one side. Sometimes it's because the other side of the SI joint is not moving enough. There are a lot of ligaments that are attaching to the sacrum from the pelvis. So it's not crazy to understand why there can be so much pain at the SI joint. It's really a big weight-bearing part of your body, right? Because after the pelvis, where this center of gravity is going down into, then it goes into the legs. So there's a lot of weight that is being bared through this SI joint. And if you have an area that's not moving enough, then you're going to have an area that's moving too much. And that can be extremely painful because of all those ligaments that are just stabilizing to be able to take the weight of the whole upper part of your body. The way that this kind of comes about, though, is you'll get this feeling of just instability in the area and this really intense pain along the SI joint, so right along that joint line. And that usually says that the ligaments are the ones that are being affected. And if you think about it, if you look at the sacrum and anatomically, it's like the shape of a triangle where the point at the top is actually at the very bottom. So the base of the triangle is on the upward side and coming down to the point lower down. Now, the example of the SI joint can be kind of an easy one to figure out, right? Like just test one side of the sacrum and then test the other side. But what if the issue of the hypomobility is coming from a completely other joint? So looking at the knee, there's a lot of people that have pain in the front of their knee, especially when they go downstairs. They'll get pain around the patellar tendon area, right around the kneecap. Now, a lot of people will then be diagnosed with patellar tendonitis. Great, that's a diagnosis, but what caused it? It could be that actually the ankle isn't moving enough and it's causing the knee to move too much. So let's kind of understand this. When you're going down the stairs, your ankle needs to fold. It needs to bend. So your toes need to get closer to the front of your tibia. If it can't do that, if it can't get that motion, if it doesn't have that what we call dorsiflexion, then it might cause the tibia at the other end, which is being at your knee, to then shear too far forward, thus stretching your patellar tendon and causing the tendinitis. So you could spend all this time focusing on your knee and getting good mobility of the kneecap and then strengthening your quads when the problem could really be in your ankle. It could be that the ankle isn't bending properly and thus causing more hypermobility, more motion occurring up higher at the other end of the tibia at the knee and irritating the patellar tendon. So to really fix the problem, you're going to have the ankle treated and figure out what joints are limiting that motion for the efficient motion down the stairs. Let's talk about the spine, though, because the same kind of joint hypermobility can occur in the spine. You want to see as someone is moving that there is an equal transference of motion throughout the entire spine. So even when you turn your head from side to side, in the most efficient state, you'll see that rotation happening down the entire spine, and they'll actually weight shift onto the opposite sits bone. So if I was to be looking to the right, I want to see motion occurring down my entire spine, that it's rotating to the right, and then my weight is shifting over to the left sits bone. That is the most efficient state. So if that's not occurring as someone is moving through all different physiological motions, so that's rotation and flexion, extension, any of those movements of the spine, if it's not moving properly, it could be that that side of pain is actually an area where there's too much motion. And you got to look above and below it to see what sort of mobility, what sort of transference of motion is occurring at those segments. Because it could be that those are the ones that aren't moving, and then they're causing that hypermobility in that spot that's painful. So you want to be able to see as someone's moving into the motions that cause them pain, especially when it comes to the spine, if that's happening all up and down the spine as well. And you need to treat those joints as needed. So what if the joints aren't the problem? What if it's actually the nerves that there is a hypomobility in the nerves, and that is causing a hypermobility. Now remember, the nerves go the entire length of the arm or the leg. It goes from the spine all the way down to the ends of the limbs. So if any point in there you have a hypomobility, the nerve isn't moving well enough, it can cause a hypermobility elsewhere. Where I see this most often is actually with overhead upper body athletes like swimmers or throwers. They're the ones that are dealing with this more than anything. And what they might get there as their diagnosis is multidirectional instability of the shoulder. That is a very common diagnosis for overhead athletes to get. And what surprises them over and over again is that it's not that they're just so loose in all their joints, in their shoulder especially, but it's actually because their nerves are way too tight and they're causing that multidirectional instability in through their shoulder. They're causing that ligamentous laxity because they're asking so much out of their arm, especially those athletes that are, throwing at high velocities. You'll see this a lot with pitchers because there's just so much force and inertia that's going through as they're trying to throw the ball that their body is like, we have to have the motion happen from somewhere because the nerves are not moving. So it will make the shoulder move in weird directions that can cause pain. Now, I was a competitive swimmer and I had this same issue where I was diagnosed with multidirectional instability of the shoulder. And all I was given was exercise after exercise to just strengthen my shoulder muscles, but it never worked. And the reason why it didn't work was because my nerves were way too tight going down my arm, and it caused the difference of motion to occur into the shoulder. If you remember to the hierarchies of the organ systems, nervous system reigns supreme with the cardiovascular system. So if my nerves are at any threat to get injured, it's going to change how my musculoskeletal system works. So I have to treat out the nerves and get the nerves moving better, get the dura, that saran wrap, the plastic wrap around the entire nervous system. That needs to be moving better. And then their shoulder doesn't need to go into these crazy motions to be able to do what they're asking of it. So the nerves can have a huge component of this hypomobility, causing a hypermobility and pain elsewhere in the body. Now, I have also seen this with some runners that have had a former hamstring injury. So they tore their hamstring when they were running. I've seen this a lot more with hurdlers. So the ones that are asking a lot of that leg extension, putting a lot of nerve tension on there, that they had a previous hamstring injury, but now they have pain in their low back. And if you look at it, that L4, L5 is just moving a lot. It has this hypermobility where it's moving way too much as they're going through their stride. And it's because of the nerve, the sciatic nerve that kind of got hung up and scarred down because of that hamstring injury. The repair of the hamstring injury led to kind of tying down of that sciatic nerve dura, which has now led to a hypermobility of the lumbar spine. The motion had to come from somewhere, right? They're asking a lot of their bodies to go over these hurdles and stretch that front leg out, and it's got to happen from somewhere, so it's going to come from the lumbar spine. That's the easiest place for it to come for, and from these patients that I've seen. It's not the hamstring, it's not the knee, it's not the pelvis. It's usually the spine that just ends up moving way too much because their tension is there, and there's got to be an area of hypermobility to be able to do what they are asking of their bodies. Also kind of focusing on the spine. Have you ever heard of a spondylosis or spondylolisthesis? It's kind of a shearing forward of the spine at one segment. It usually happens in the lower spine. You see it often in gymnasts because they're always going to extensions, or you see it in dancers, but you can see it in other people too. Now, that spondy was what the nickname we give it. The spondy is often caused by increased neural tension, that this tension in through the spine, so the spinal cord more specifically, was built up so much from either a injury to the tailbone or an injury to the sphenoid bone, the bone the brain sits on, or anywhere else through the spinal column, that it built up so much tension that then the only thing that could happen is a segment just shears forward. It just goes forward just to relieve the tension. And with that relieving of the tension, it causes this hypermobility. And I see patients struggle all the time with spondies because they just can't create the stability to keep that segment back where it needs to. The muscles aren't able to hold that spinal segment back to be in that efficient state because there's this underlying tension, this hypomobility of the nervous system, which is going to reign supreme, that is causing that shearing forward of that segment. There's no other place for it to go. It's either an injury could occur to the spinal cord, which your body does not want, or there's going to be a shearing forward of that one segment. So that segment's going to win out. And you're not going to get it back into place and get it to stay there until you address the hypomobility of the nervous system. The issue with the nerves definitely causes the most frustration for patients, and it's the one that I see most often in this paradigm of hypomobility versus hypermobility and what is the root cause in finding that leak of the injury. Because these patients have tried so much to stabilize and to strengthen that area that's causing pain, and it just does not maintain. And it makes sense if you think about the hierarchy of the organ systems with the nervous system reigning supreme. It's not going to maintain because your body is more importantly trying to save the nervous system and make sure that no undue injury or harm occurs to it. So this is the one where patients are just beating their heads against the wall all the time of like, why do I deal with this pain? Why can't I get to stabilize? When they're not addressing that root cause of the injury, that leak in the ceiling is the nervous system. Now, another more kind of obscure for some people to understand reason for this hypo versus hypermobility issue could be an organ that's restricted. Now, it doesn't mean that the organ isn't functioning properly. It's more the fascia that surrounds the organ. And if it's not moving, then it can cause a hypo versus hypermobility issue. Now, I'll give two examples for this. So one is for upper extremity, one is for lower extremity. The stomach length is varied person to person, and some are more efficient than others. Now, the top of the stomach is pretty much the same for everybody. It's the landmark of between the fifth and sixth rib space is actually where the start of the top of the stomach is. Now, for most people, that's about nipple line. That's the same for everybody. That's kind of where, when we're teaching courses, that's where we try to capture the top of the stomach. But trying to catch the bottom of the stomach could be literally right underneath the ribs. Should be at the level of the belly button, or it could be below the belly button. The problem that I see with the lower extremity issues and when it comes to the viscera or bringing in the stomach is when that stomach is stuck down lower than the belly button. It might be that it's just long, and that could be part of it, but usually it's because might be an injury that occurred that caused some inflammation that made it so that that bottom part of the stomach adhered down to lower in the abdominal contents. Now, do you think it's more important that your stomach is working properly to digest nutrients, or that you have efficient mobility of your lumbar spine? I would hope you understand that the stomach needs to be working more than the lumbar spine. You can deal with some low back pain, that's fine, because if your stomach's working, that means it can, process the nutrients and you will still be alive to feel that lumbar spine back pain. So what I find with this stomach that's stuck, it's stuck through the front side. If it's not moving, then you'll see a lack of mobility of the lumbar spine where it doesn't go into extension mostly. What you'll see with a stomach adhesion is that the lumbar spine won't go into extension. And it might be more that if someone tries to go back bend, that they will bias themselves a little bit to the left-hand side where that stomach is because you don't have the mobility there. So you've had to kind of rotate and side bend to that side so that you're not stretching that stomach so much. So the cause of that abnormal movement or that aberrant movement is actually because the stomach in the front is stuck. You'll see this with runners that have pain on the top of their pelvis or the top of their iliac crest on the left-hand side, because that stomach, the bottom part of the stomach might be adhered just a little bit above that. So you don't have the normal lumbar spine mobility that you need to when you're running and you're asking to really push off through that back leg. And so now you have this spot of hypomobility that's going to create this hypermobility and really stretch the tissues and strain the tissues right underneath there, right above the iliac crest. So if you see someone that's having this pain right above the iliac crest, it's just not getting better, and it's not because there's a leg length discrepancy or that there's any sort of SI joint pain, it could be that the stomach is stuck on that side, and that's what's causing this hypermobility and the pain that they have right above their iliac crest. So what about the upper extremity? Let's talk about the liver. The liver is huge. Oh my goodness. If you guys look up anatomy pictures, which you probably won't, but I do because I am just a big nerd, the liver is massive, massive. So it is starting, so the stomach was starting between the fifth and sixth rib space on the left-hand side. The liver is starting between the fourth and fifth rib space on the right-hand side, so even a little bit higher. And it goes all along the back side of your body, and it goes down, falls along the lower border of your rib cage into your abdomen, and actually crosses over and is on the other side to what we call the mid-clavicular line. So like halfway through your clavicle or your collarbone on your left-hand side, if you were to draw a line halfway down, right around that fifth, sixth space too, you'll actually get the left lobe of the liver. So the liver is taking up a huge part of your rib cage, much bigger than people realize, because remember, it's starting up right around nipple line is where that stomach is starting from. And it's going all the way over to partially over to that left-hand side and encasing the whole right side of the lower rib cage. So can you imagine the issues that you might have if that liver's not moving properly? Here's a fun experiment you can do. Don't do this if you're driving, only if you're in a place where you are not operating heavy machinery. With your right arm, go ahead and lift it overhead. Go through flexion. So go through the kind of going up in front of you and up over your head, and feel how your shoulder can move that way. Now take your left hand and pull down your shirt, like right by, for women, like the bra line, for men, just right underneath their pec. Just grab that shirt and hold it down. Hold it down so it can't move. Now try to move your shoulder. Most likely, you're not going to be able to get your arm quite as high and up overhead. So just imagine if that was your liver that was stuck right there and not allowing for motion of that rib cage. It's going to affect how that shoulder can move. But it might actually cause that hypermobility of the shoulder. And patients will have kind of impingement pain through the front of their shoulder, pain in through the front, if their liver's not moving properly. So if that liver's not moving, it's not allowing the rib cage to move, and you need that rib cage to move when you move your arm overhead. So it could be leading to issues elsewhere, and you have to treat that liver out. Now, remember, it's the fascia around the liver that's the issue, that's what's needed to be treated to improve the rib cage range of motion. So even though it seems a little bit more obscure as to how an organ adhesion could cause a hypo versus hypermobility issue, I hope that those two examples kind of start to open your mind as to other possibilities and why you might not be getting better, because it could be because an organ that's the issue that's causing this hypermobility through your system. So now that we have a little bit of a better idea of what the hyper versus hypomobility scheme is here, where it could be the joint that's actually the issue, it could be the nerves, or it could be an organ, how the heck do we figure this out? And then how do we treat it? A thorough and comprehensive assessment is the answer for this. Now, this is on the patient and also on the practitioner to be able to do this. So you need to be able to improve your ability to watch as motion's occurring and see does this look efficient? Does this look like the transference of range of motion is equal? That it's not getting stuck, there's not a pivot point in one spot, or there's not some weird aberrant movement occurring where they're moving out of a range of motion, that they're adjusting and compensating. So that needs to be able to be assessed through observation skills. And patients, you need to start watching yourself too. This is on you as well. It's not just on your practitioner. You need to be able to see this as well. The other component is you need to be able to feel in your body, and practitioners, you need to feel in your patient's body where it's not moving. So when I have a patient in my room and we're assessing range of motion, I might actually have my hands on them because I want to feel as they move, where is it not moving? Because I know what efficiency is. I know what it should move like. So where is this person not moving properly? Where is this area of hypomobility that could be the cause of their pain? So it's important that you can start to feel through their system. Now, that doesn't mean that practitioners, you are guiding them through that range of motion. No, you are along for the ride. You want to see what they do naturally. You don't want to try to put them into what you think is the most efficient alignment. No, they need to do it themselves. And then once you feel where it's not moving right, where all of a sudden you hit the spot of hypomobility, you need to get the patient to recognize it as well. They need to feel through their own system where they're not moving efficiently from. Because if the paradigm of their issue is because of this hypermobility, then you don't want them to move into this hypomobility and try to move past it to get to this area of hypermobility that's causing all the pain. So, I talk about the leak, so we'll kind of go with that analogy. So patient, if you have a leak in your ceiling and I tell you that the leak is coming from your upstairs bathroom, more specifically the sink, do you think you're going to go and turn on that sink all the time, expecting that it's going to be better all of a sudden until I fix it? No, I would hope not, at least, unless you really like paying for plumbing bills and fixing of the roof and drywall. No, you're not going to do it if you know where it's coming from, where that leak is coming from. You're not going to feed into that. You're not going to turn it on. You're going to try to avoid it until it gets fixed. You'll be able to turn that sink back on after your wonderful handy person is able to fix the plumbing issue so that it's no longer leaking and destroying your roof. So just have that know-all patient. You have to take responsibility for your body as well. It's not just on your handy person, because let me tell you, I think any plumber that tells you that your leak is coming from that sink and you go and keep turning on the sink, they're going to get frustrated with you. Like, I told you, let me fix it first. So it has to be this relationship between the practitioner and the patient to educate both of you as to what is going on in your system and how to avoid any more problems occurring. I hope this starts to open to your mind the different causes of your pain. Like I said, this is going to be kind of a series of podcast episodes that I'm going to do that are going to be interdispersed randomly throughout other ones, just to try to get to that leak and figure out how to stop your pain. Thank you for tuning in to this episode of the Body Fusion Therapy Podcast. Please share it with your friends and family, as well as leave a review if you liked what you heard today. We're looking forward to continuing this journey of looking at the body. Tune in next time.